Good afternoon and welcome to another edition of Focus on Facebook Live. My name is Hasnain Kermali. I'm the Chief Medical Officer here at St. Mary's Hospital in Waterbury, Connecticut. Each month we like to bring you a little expose on our excellent services and opportunities that we have here for our patients in the Waterbury community, and sharing with you some of the insights that those providers give us. And this month, of course, February, we're in the middle of Heart Month, just days away from Valentine's Day. A perfect time to bring on one of the esteemed members of our cardiology team, Dr. Mohammad Kashef. Thank you so much for joining us.
Thank you so much.
Dr. Kashef joined St. Mary's and Trinity Health just about a year ago. He's a skilled physician, of course, a cardiologist in training, specializing in both general, interventional, and structural heart disease. And so we're very excited to have him here. Deep knowledge and both interest in interventional, but also structural heart disease, talking about TAVR, Watchman, and mitral clips and more. And we're going to get into that all in a few minutes as well. So thank you again for joining us.
Thank you so much for the opportunity and for the introduction.
Oh, for sure. So before we get into it, let's start talking about you as a physician. What drove you to go into either medicine and then, of course, cardiology?
Well, it was a while, quite a long time ago, but I would say for medicine, I had interest in science and problem solving, and I was also influenced by family members.
Okay.
In terms of cardiology, I was always fascinated by physiology of heart and cardiovascular system, and with all the new treatments and innovations, and with the treatments that can rapidly improve the patient's condition, I found the cardiology to be mostly aligned with my interests in the field of medicine.
Beautiful, beautiful. Now, in cardiology, we think, oh, you're a cardiologist, but it's not that simple. There are divisions of cardiologists. And so tell us a little bit about what drove you to say, hey, I want to be an interventionalist, and what does that entail? What do you do on a day-to-day basis?
Right, so as an interventionalist, in addition to treating patients with general cardiology conditions, we also treat and do procedures that are transcatheter.
Okay.
There are different types of them, but most common is transcatheter treatment of blocked arteries.
Okay.
And that's what we call coronary artery disease or atherosclerosis.
Gotcha.
Especially in the setting of heart attack, which is acute blockage of the artery of the heart. As you mentioned, cardiology has advanced a lot, and there are a lot of branches. One of the branches of interventional cardiology is structural heart disease, which includes transcatheter procedures for other cardiac conditions other than blocked arteries. It could be a heart valve or other conditions.
So let's talk about first that heart attack. Somebody comes in with a heart attack. They're being notified in the field. We're being notified that a patient is arriving. What's your role on that team specifically?
So there's a specific type of the heart attack, and that's what we call a STEMI. That's been diagnosed based on patient symptoms, presentation, and EKG. Mm-hmm. So at that time, we usually get a call from emergency medicine doctors or one of the other colleagues. We discuss the patient, what they know and what they have examined the patient, and we review the EKG. And at that point, if we think patient would benefit from an emergency procedure, which is a cardiac catheterization, angioplasty, or stenting, then the whole team will be activated, and that's a cath lab team here in St. Mary's Hospital, which we do this procedure together. So usually 3 or 4. That includes nursing, cath lab technicians, and me. They're very efficient. They have done this many times.
Yeah.
So they're really good at what they do. It's only a teamwork that can achieve a good result.
Oh yeah.
In this type of situation. And then after that, the patient will go to the ICU for further management.
So, and you say a team, because I remember we were doing that Walk a Mile in Their Shoes program, and I got the opportunity to stand beside one of the technicians and one of the nurses while watching one of these procedures going on, it's amazing to see how coordinated it is, with you clearly directing the catheter from either the wrist or through the leg up to the heart, clearing out that blockage, but everything that they're doing along the way, making sure that all the vital signs are stable for the patient, making sure that the next piece of equipment that you need is readily available, that sterile technique is maintained, monitoring the patient, like you mentioned. So I think that it was beautiful to watch that team truly orchestrating the care of that patient in this life-threatening indication. And then how well the patient does afterwards. We've got the program here where the patient then goes directly to the intensive care unit.
Right.
So they're going to be monitored very, very closely, watched very closely to make sure we get those best outcomes. But it's fantastic to see that team approach, again, all surrounding the patient being the key in the middle.
Absolutely.
So not only are you part of cardiology, but you also have a master's in public health. So has that extra layer of knowledge helped shape sort of, hey, this is how I need to truly engage with the community?
Definitely. I would say it really broadened my understanding of population health, preventive strategies, healthcare policies, and research methods, including epidemiology or biostatistics. And prevention is a very important part of cardiology, especially when we talk about community and populations.
Right.
So it really helped me in that regard. So we're implementing the preventive change strategies not only to patient, but also community-wise.
And when we think about Heart Health Month, like February is, it's all about prevention. We don't want that STEMI to come through. We don't want patients to experience sudden heart attacks. And so preventative things that they can do, especially this month or starting from this month, are going to be critical.
Absolutely.
How does that then help the community? What impact, when communities are doing well from a prevention perspective, how does that help across the board?
So, as we know, heart disease is the most common cause of death worldwide. 1 in 5 Americans die because of heart disease. But the good thing is that it can be prevented.
Yes.
By early detection and by prevention. So we can really change the course of the life of a person and also quality of life by educating them, by empowering them to implement preventive strategies, including managing blood pressure, checking cholesterol, checking blood sugar, having regular checkup with doctor, diet, physical activity. It really improves the longevity and quality of life of each person in the community, which could be one of us or one of our friends, one of the relatives or loved ones.
Yeah. And the way that I see it is when a patient, not only are we empowering them to take their own health matters into their hands and really shape it for the better, but we're helping the entire family.
Yeah.
Because it's not just that individual that has an impact.
Affects everyone.
Right? So a death, 1 in 5 dying from heart disease is a terrible number. I know heart disease isn't proud of being the number one cause of death, but the impact of that patient leaving their family, leaving their community is deep.
Absolutely.
And so being able to prevent that is great for the family, great for the community as well. So let's talk back about cardiology. Let's talk about our team. Our team doesn't work just by itself here in Waterbury. We've got an entire regional team that collaborates. And so we've got a number of complex conditions that you now come and joining us are really able to be facilitated and introduced for the community in Waterbury. Tell us a little bit more about that. How do we work together with the regional team?
So here in Waterbury, we provide the full spectrum of cardiology, including preventive care, testing, treatment, general cardiology, and also treatment of heart attacks, stenting. In collaboration with the regional team, we have cardiac surgeons, we have vascular surgeons, we have stroke specialists. So patients who need a cardiac surgery, they get treated and they get their surgery through the system. and also structural heart, which is a growing field of interventional cardiology, especially over the past 20 years.
Right.
That could be treatment of heart valve disease by transcatheter, minimally invasive procedures, either replacing the valves or in some cases repairing the valves.
Yeah.
Or in the case of atrial fibrillation for patients who cannot take blood thinner. So we are able at this point to see these patients here in the community, do their tests, do the workup, consultation, answer all their questions, get them ready and have their procedure done inside the system, inside our Trinity Health of New England system.
Yeah.
And they'll have their procedures, the follow-up test and the follow-up clinic visits locally here in Waterbury Hospital.
Yeah.
This provides better access to care to our patients, more continuity of care, so they trust the physicians. Their referring cardiologist is here. So there's a lot of support for the patient.
Yeah.
This will definitely be a good thing for our patients, for the hospital, for the community.
You know, and when I think about these pieces, we especially in America sometimes don't recognize the beauty that we've got here, in that many times you'll have, you know, just a program that starts at a larger institution, and the complexity is great because they get a lot of different types of cases that come in through there. So not only is the complexity high, but then the quality of care is also pretty high at those institutions. And that allows then for, like you mentioned, patients get seen here in Waterbury. We're going to be able to manage them all the way around. They get managed within the system for their procedure as well, and continue that local follow-up care here. It really allows them to connect because it's still the same provider that's doing the procedure elsewhere, but they've just seen them here, and procedure might be somewhere else in certain instances. So again, opening that access, like you mentioned, for the community to really allow it to flourish, get that health here for the patients that need it right here. They don't have to travel very far for it either.
Absolutely.
So, you know, I think that creates that opportunity. But tell us about these new techniques. You talked about patients who've got atrial fibrillation that can't take blood thinners. That's brand new, or maybe not brand new, but newer that we haven't really heard about. Tell us about that. Yeah,
so that is a procedure that we call it the left atrial appendage occlusion.
Okay.
Mostly in the United States, it's a Watchman procedure.
Okay.
And what it does is it blocks part of the heart that forms blood clot and is a source of a stroke in patients who have atrial fibrillation.
Gotcha.
Patients who have atrial fibrillation have, on average, 5 times more risk of stroke compared to other people who don't have atrial fibrillation. And that's why we prescribe blood thinners. There are some patients who cannot take blood thinners because of bleeding, because of falling, or other reasons. And Watchman provides an alternative for those patients to prevent a stroke.
Sure.
It's a procedure that is considered safe, low risk, and so far the studies that have come out shows that for patients who cannot tolerate the blood thinner, Watchman is as good as blood thinner. So we're offering this to our patients. This is one of the structural heart procedures. The others are, most common one I would say, TAVR procedure, which is a procedure that was first performed in 2002, and it has really grown and advanced, and there are a lot of innovations in it.
Wow.
So it is currently as good as open heart surgery for management of patients who have severe aortic stenosis, which is a type of heart condition that is narrowing of aortic valve. Nowadays, patients, especially patients that are older than 70 or 65, have the option of getting TAVR procedure. And the good thing about this procedure, and I would say most of the structural heart procedure, is that, again, it's done as part of a teamwork, and it's a multidisciplinary approach, meaning that a heart surgeon, a cardiologist, an interventional cardiologist, cardiologist who does the imaging, radiologist, they're all involved. So different aspects of this being studied by everyone to come up with the best decision for the patient.
It's remarkable. We talk about AFib, and as a hospital physician, that was one of the big things we would see. Patients coming in with stroke. We look at their heart rhythm. Oh, they've got atrial fibrillation. The next question is this: well, what do we do about their keeping their blood thin so that they don't develop further strokes? Or patient who come in, my heart's racing, I don't know what's going on. They've got this AFib where their heart's racing. And that's that next question. But you're right, there's a whole number of patients that can't take blood thinners.
Yeah.
And for whatever reason, or we'll start them on them and then we'll see them soon after, or the next day, all of a sudden they're bleeding from somewhere else. And it's like, well, wait a second. But now we've got an option for them as well, which is fantastic.
That's great.
And then we talk about TAVR, where again, it truly, this transcatheter aortic valve replacement therapy, revolutionary. My dad had it done, and it was amazing when we talked about between the open versus the transcatheter approach. And it's great that we're able to do it in the United States, because in other countries they don't offer it as readily as we do it here.
Right.
But it's safe. Patient-centered, but multidisciplinary. There's the entire team that comes around it, which was fantastic to see.
That's great. Yep.
It's again changing, and now we're moving away from open heart procedures to get this done.
That's right. That has been the trend. Most of the patients for aortic stenosis are getting TAVR. It still requires that careful, meticulous discussion with the patient and the surgeon. But that's the overall trend. Yeah. Open heart surgery with aortic valve replacement, obviously, it's still being done.
What about mitral clip? That's something new. We think TAVR, 20 years, Watchman or the left atrial appendage closure device, maybe 8 to 10 years. Yeah. Tell us about mitral clip.
So mitral clip is a procedure on one of the heart valve. That's a mitral valve. Mm. It's the valve on the left side of the heart between the upper chamber and lower chamber of the heart. This is a treatment for patients who have severe or moderate to severe leaking of the valve, which causes shortness of breath, which causes congestive heart failure. There's a subtype of these patients who benefit from surgery, open heart surgery, and there's a subtype that also are not a good candidate for open heart surgery.
Gotcha. Why is that? Why aren't they a good candidate?
Well, it could be for many different reasons. It could be other comorbidities. It could be that the risk of operation is too much, or the recovery would be difficult after a major surgery. So mitral clip is an option for those patients to have their heart valve repaired. And pretty much what it does, it's a clip that is done transcatheterly from the groin. We bring the front and back of the valve together. It will reduce the leaking of the valve.
Gotcha. Wow.
And then there's also another subtype of leaking of mitral valve, these are the patients who have enlarged heart, and those patients usually don't get open surgery. And the mitral clip is an option after medications and after, again, a multidisciplinary discussion with cardiologists, with heart failure specialists, and with the interventionist.
It is remarkable to think about these advances, because throughout my training we would worry about these patients, the family impact, like we talk about, the community impact, and now in a very safe and effective manner, changes their lives immediately. I remember even for my dad, when we talked about the transcatheter transaortic valve replacement, he wouldn't be able to walk a certain distance, and it would start to affect him. And now he's telling me just last night, I'm out 30 minutes at the mall, I'm doing my laps, and that's great. Completely changed his life overnight. And this is the same sort of thing for people who couldn't get a solution, now have one available for them. It's remarkable what you and other physicians are able to do, but having that access now is even greater for the community here in Waterbury. Because again, keeping that patient in the center of this multidisciplinary approach. Love to hear it. So a couple of things as we come to the close of our quick conversation. Two things we want to talk about. The first thing was a new process that we implemented for this new year. So we're learning, we're trying to adjust our ways as well. And what we asked of our last presenter, Dr. O'Brien from Neurosurgery Group, we said, give us a question that you want to have for the next presenter. He didn't know it was going to be you. We're going to ask you the same question as well. But his question was, give us something that you've learned, or tell us about something that you've learned from a colleague recently that you have decided to implement in your day-to-day practice.
It's a good question.
It's a good question.
And I would say we learn so much from each other in the medical environment. That in a way, we don't think about it because we're constantly learning from each other. I would say for me, more recently, it's been a lot of learning about Epic.
Okay.
Which, as you know,
sure,
it would take some time, and I'm implementing that every day.
Yeah.
But that's just a small example.
So, we talk about Epic. So Epic, for those who don't know, is our electronic medical record. And we just changed from one to the other back in November. So, and you talk about, it's not always the clinical, but it's the tools that we have to make our lives easier. Sure. And the electronic medical record is one of them. And you're right. We learn about things all the time from our other colleagues. Hey, do this. And all of a sudden you saved yourself 5 minutes.
Right.
Just in getting the patient information, allowing you to save that time throughout the day and seeing that one extra patient. So those are huge, small little tips and tidbits on electronic medical record. That's a great piece. I love that. So in that same light, a question for you, from you, for the next presenter. We're going to record it, make sure we keep it readily available. We don't know who that's going to be yet. So give us a question that you would love to ask the next person going forward.
I would say, what is the most important thing that they like about their job?
Okay. What is the most important thing they like about their job? We will find out in a little bit of time. And then the last tidbit for our viewers. Love to have a pearl, what we refer to as pearls or nuggets, for the viewers of our show to be able to help their lives moving forward from you as a cardiologist.
Yeah, so, obviously February is the American Heart Month.
Yes.
So in that line, I would say I want to emphasize that the best medicine is prevention. Great. So we should every day take at least one small step to improve our heart health. That could be exercise, that could be healthy diet, and that could be also avoiding harmful habits, including smoking, and also reducing stress. Every little step will count in long term. I have one other point to mention, and that is I would like to encourage everyone that are interested to learn CPR. That's very important because out-of-hospital cardiac arrest still has a high mortality.
Gotcha.
And based on research, we know the best way to improve the outcome from out-of-hospital cardiac arrest is learning CPR and bystander CPR. So I would encourage everyone to learn CPR if they can. Make sure to check the resources, including American Heart Association, for information about the heart healthy tips, CPR, and resources in terms of the symptoms that they should monitor for early detection of heart disease. You brought up a great point. It's just learning CPR. Basic life-saving procedures can be great, particularly today when the AEDs are out there and available to be able to shock a person's rhythm back in if necessary. So agree with that, Pearl. I'm going to re-emphasize it, and we'll try to provide some information on our post as well. The opportunity to learn CPR is great, and to be able to help save that individual while 911 services are coming on board is huge. So love that. And that preventative strategy, take that one step every day. We talk about it, and we're trying to reinforce it here as well at St. Mary's Hospital. Taking the stairs as opposed to taking the elevator is one of those small steps that you can do on a daily basis that can help your heart health. Thank you very much, Dr. Kashef. Really appreciate it. And thank you all for joining us. We'll see you next time.